When I ran for Congress, I said, if you want to change Washington, send a Marine. I meant it, and that's exactly what I'm working to do. Over the last few months, I've been working hard to fulfill my campaign promises. I voted to repeal Obamacare, to cut wasteful spending, balance the budget, and strengthen our national security. I've led investigations into malpractice at veterans hospitals nationwide and secured passage of the VA Reform Act to ensure our veterans receive the care that they earned. I've been fighting the entrenched bureaucracies that have been hurting our nation, stifling job growth, and holding back progress on important issues like the SULOCs, veterans health care, and tax reform. Here's the bottom line. I'm working hard to change Washington, but as you already know, the odds are stacked against outsiders like you and me. Special interests, biased media, and bureaucrats on both sides of the aisle are entrenched in the halls of Congress. There's a major roadblock to getting good legislation on the president's desk. That roadblock is the United States Senate. Far too many Democrats and liberals in the Senate are working tirelessly to stop the House's conservative agenda from reaching the president's desk. But you can help. As you know, in 2018, Debbie Stabenow is up for re-election. It's time to send a Republican senator to Washington who will help push President Trump and the House's agenda forward. Debbie Stabenow is a career politician, and as Michigan showed in 2016, we are done with do-nothing politicians. That's where those of you sitting in the audience come into play. It's time for a change in Washington. You sent me, you sent President Trump, and now it's time to send a conservative to the Senate. Now is the time for us to join together and keep working to drain the swamp. Thank you for all you continue to do, and let's win in 2018.
All right, well, we're glad you all made it tonight, and we've got a very important guest here tonight. Mr. Ed Ness is here with us tonight. He's the president of Munson Healthcare System, and he knows a lot more than healthcare than any of us probably know at this point. We hope anyway, right? I've known Mr. Ness and his lovely wife Laura for a long time. They're very active in the community, very active in skiing. Ed and his children would come into Donwar Ski House and get fitted every year and get them all set up to race down the hills here in our area. His wife Laura has been very, very active in the Hickory Hills renovation over there, and we appreciate that. In the ski business, just a little side thing, but appreciate all the hard work, guys. So without me talking and rambling anymore, we'll let Mr. Ed Ness come up. Thank you, Ed. Thank you.
Yeah, thank you. I just want you to know that the reason I'll be working till I'm 70 is Donwar Ski House. It's always fun. Any retirement. Well, thanks for having me. I hope you know I have the most fun and joy. If you have questions as we go along, it's much more fun than just standing up here and talking about this. And there's all kinds of. We can spend the whole night in one slide if you'd like to. It's really up to you. Can you hear me in the back? Okay, is it okay? So maybe a bit about, when you hear about Munson in the north, this is a map. The colored area is where our patients come from. So the colored area, there's about 500,000 people in that service area for Munson. And that's where our patients come from. For Munson Medical Center here in Traverse City, about 70% of the patients come from that yellow area. But if you take things like open heart surgery or cancer or some other things, 50% come from outside the area. So it's a very big geography for capture of patients, which is very unique. There's probably a couple systems in Montana or maybe the Dakotas that have that big a service area, but it's up there in the small list. So these are the hospitals that are in the Munson system. The ones that are dark blue are the ones that are fully owned or fully integrated. The ones that are light green have a little bit of a different relationship. And this is a lot different than it would have looked 10 years ago if we were sitting here. most of these hospitals would have been independent. And now, in fact, if you look at all the hospitals in northern Michigan, Alpena just recently became part of the Mid-Michigan system. Of course, Petoskey's part of the McLaren system. There really, until you get up into the UP, are no hospitals that aren't part of a system. So why is that? I mean, part of that is just the cost of things like information systems, the cost of technology, the cost of, and frankly regulation, all the different rules that the hospitals have to go through. You need some centralized experts who can go through those things. So what is our goal as a system? Really, in simplest forms, is that a patient can enter the system at any one of those places, go back and forth to the system, and it's seamless, which I'm sure for many of you have had healthcare, historically, it's not necessarily seamless. So, you may see a local doctor and then have to go to the hospital and you get asked the same questions, and maybe you have to have your lab test redone or an x-ray redone. And the goal is that you can go to Charlevoix, go to your local cardiologist, have something with your heart, come down to Traverse City, maybe have something done, and then go back and have cardiac rehab in your local community, and that flows pretty seamlessly. We're not there yet, but that is the goal. So again, this trend is not something that's just here in northern Michigan, it's what's happening across the country. So again, 9 hospitals, you can see all the 8,000 employees. We now are the largest employer of any business north of US 10 in the state. So healthcare is not only a big provider, but it's also a big economic. Most of these, in all of our communities, we are the biggest employer. And that has 2 sides to it. I mean, one is it's good for the economy, but yet someone's paying those bills. And so it costs a lot of money. So this is kind of a summary of it. So who does pay the bill for a hospital? And I would say this is Munson's numbers, but I would say it is probably not that different than other systems in the state. So about 50% of the patients that come into our system are Medicare. About 11% are Medicaid. Again, I think you all know that Medicaid tends to be a state program with some federal match. Self-pay is mostly those without insurance. And then of course there's this Priority Health and Blue Cross make up the difference. So I'm sure there are lots of different opinions about government involvement in healthcare, but the reality is for us about 65% of how we get paid is government. So is that good or bad? I don't know, but it's there. And that is going up every year. If I would have done this 10 years ago, Medicare probably would have been closer to 45%, Medicaid would have been 7-8%. So that piece of how we are reimbursed at the hospital has been growing. Medicare goes up because in northern Michigan we are aging, and so there are more people that are Medicare age. And Medicaid changes based on eligibility, and we'll talk about that. That has been a shift from this self-pay, no insurance, to Medicaid. Any questions on that or on the first map?
I'll ask one question on the why it switched to the bigger circuits of hospitals. Is there a certain thing that happened that occurred to make it go that way?
To flip?
Yeah.
So I think it's 2 things. One is it's called the meaningful use. It's the requirements to have electronic medical records, so in the next 5 years we'll spend $60 million on IT systems. Certainly if you're a small hospital, you can't do that. And then I would say the other is access to capital. Just how do you replace your facilities? They're probably the 2 biggest things that have switched. Yes?
After you stay in the hospital, they send out, or somebody sends out, the report that you have to fill out that, did you enjoy your thing, was it good, was it bad, da 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 da. In the old days, in the old days meaning 10 years ago, I thought that your reimbursement from Medicare depended on how good your rating was. I can't remember the name of the company that does it.
So there's many companies. Ours happens to be Press Ganey.
Press Ganey,
Yeah.
that's it, right. So is that the way it works?
Yeah, so there's, in Medicare today, there's what I'll call a base, you get paid a base amount, and then there are either incentives or penalties that happen depending on how you do on a series of metrics. So some of those are patient satisfaction, some of those are like how you do with infections, some of those are readmissions. There's probably 15 different things. And then how you score, it's a zero-sum game in the country, so there's 50% of hospitals get penalized and 50% that get rewarded. And it just depends on how you, so it is still part of the formula.
So it would behoove everyone to fill it out if they're very happy with their stay, right?
That would be awesome. You know, just a bit in the business of healthcare, which is, so if you look at covering costs, Medicare is about a break even for most hospitals. Munson is about a 1% margin on Medicare. Medicaid is about losing 25 cents on the dollar, so it's about 75 cents on the cost. On self-pay, we collect 3 cents on a dollar, so we write off 97 cents in general. So the simple math of healthcare, whether we like it or not, is so if 65% of your business is either breaking even or losing money, then how do you pay the bills? It's priority commercial, which is why there's increasing costs in those that have their insurance through, their employer or buying it on their own. Because in some ways it's subsidizing the cost of Medicare and Medicaid.
I have a question.
Yes.
Two, actually. What was the rating on Munson? You said there's a rating that, you get for the Medicaid.
Well, there's.
What was Munson's rating?
Well, it isn't like you don't get a rate. You don't get like a 97 out of 100 or something. They just say, okay, on your patient satisfaction, we'll give you a $500,000 incentive. If you take all of them together, we get about $500,000. We were positive on the incentives on those things that we were talking about. But there isn't like a card. It isn't like a report card where you could look. And frankly, that's a problem because our citizens are always saying, how do I know what the quality is at a hospital? It isn't like you can say, here's a scorecard that you compare this doctor or this hospital.
And my second question was, this breakdown that is money, how does that relate to all the other healthcare facilities, like in the country, like the way you are so 50% on the Medicare?
We would tend to be, in Northern Michigan, this would be the same in Petoskey, we're high on Medicare because of the demographics. Medicaid is completely dependent on your geography. So we tend to be a bit higher here than like Chicago would be, or a suburban community in Chicago would be a lot lower. Grand Rapids would be lower. It all depends on where you are. We tend to be higher governmental here than other parts of the country, just because of our demographic. So given again that 65% of how our business is tied to the government, we're very interested in what happens in legislature, both at the state and level. At state issues, of course, there's been a lot of activity of auto no fault, which has probably been on the attention of some of you. So, and I'm sure there's people on both sides of the issues. I tell you from a healthcare provider, there were two things that were a concern with this legislation. One is it had in it a mandated fee schedule for hospitals and doctors. So rather than being able to negotiate whatever a rate was with an insurance company, it was a fee schedule. And then it also had a cap on benefits. And I will say, I do think there needs to be some caps, but frankly, our thought is that there's going to be a lot of people that blew through the cap, and then what would happen is they'd go on the Medicaid system because we're still getting the care. And so if you run through all of your assets, you go on Medicaid, which in some ways would make the state budget worse. Now, having said that, we do have to figure out a way to get auto rates down. And I think, and frankly, I think the healthcare industry has to be more proactive, because rather than just saying, no, we don't like that, or no, we don't like that, then what is the solution? I do think there has to be some type of a reasonable cap. There's all kinds of, I think, practices on fraud that need to be reduced. I think that's a problem more downstate than it is up here, but there is a lot on fraud. And then we have to do some of, I think with some things on dependent care. So we do have to figure out a solution to this, and I think hospitals have to be more proactive in the solution rather than just saying no. There's, again, the state budget discussions every year. There's questions of whether there's going to be subsidies for rural hospitals or not. The governor has continued to put those in. We think that's good for our economy up here. And then again, what happens with the Healthy Michigan plan. On the federal side, of course, there's, as we were just talking about, with the healthcare reform, and we can talk about that a bit more. And then there's things called, 340B and drug pricing, how we pay for drugs. So maybe go through a couple of those. So let's talk a little bit about Medicaid. So this is, there's about 1.7 million in Michigan on Medicaid, about 100,000 in our service area on the Medicaid. That's that 11%. And then Healthy Michigan was the Medicaid expansion program that went in a couple of years ago. For Munson, that's about 37,000 new people. That was that shift from self-insured no pay to Medicaid. That's at 37,000. And then the insurance marketplace, that's this exchange. That's the one you hear so much discussion about, frankly, with the executive order from Trump on, is there the subsidies? That's this. So in northern Michigan, our service area, that's about 18,000 people. So again, there can be a lot of good debate about whether these are good or bad. From a purely healthcare provider perspective, it is better, however you do it, it is better for our northern Michigan citizens to have coverage than not. We can talk about who pays for it and all those things, but from a coverage perspective, they have coverage. They tend to get things treated from their primary care office rather than waiting until they go to the ER. And so if you have a cardiac condition, it's better from our perspective to get that treated in a primary care office than it is waiting to go to the ER. And people tend to do that more if they have some type of coverage. Now the difficult issues are how do you pay for it, who pays for it, and all those things. But from a healthcare provider, we're better off having insurance.
Let me ask you, have you guys seen less in the emergency room because?
Yeah, to be honest, it's a little bit hard to track because our ER has so many other things going on. We have found, for those that have been registered, they have signed up for primary care physicians. Our ER visits haven't gone down, but some of that's do we have a busy summer or not, with everything else going on. Yes, sir.
Does that hold true when the primary care physician is someone who is employed by Munson, for instance, a pediatrician in Manistee or whatever it might be, who's a Munson employee? Is that a less expensive way to take care of it than having the person show up at the hospital?
Yes. It is, because again, you hope by managing medication, let's say somebody has diabetes or some other disease, by managing the diagnosis in the primary care, you don't wait until something's acute and then you go to the ER. And any of you have been, ER is not a good place for primary care. I mean, it just is not. It's one is, especially up here with our, ER is a busy place. The ER physician's job, their mindset is, you do a quick diagnosis, what is it we have to do to get that person out? Either upstairs to the bed or home. If somebody has a chronic condition, that doesn't lend itself to a 20-minute visit or 2-hour visit, whatever it may be, until you get them out. Other questions?
What's your total Munson Healthcare? You got down by traditional Medicare expansion. What's your total demographic?
So these are the citizens. So we have 500. There's that in our service area. There's 500,000 people.
So you would count 500,000, of which these folks are paid this way.
These are the one. Yeah. So of that $500,000 pie, these are kind of the. It's not exact, but give or take, that's about what it is. You know, and it really depends, like some of these, so take Medicaid, the part that most surprises most people, so you talked about 10% overall, 43% of the babies delivered at Traverse City are Medicaid. In Grayling, it's 72%. I would say Gaylord is 60 and Cadillac, so it's always surprising to people, but you know, even in Traverse City, if you went up, you know, across town, 40% of the babies in there are Medicaid. Yeah.
Years ago, again, I keep going back to years ago, we didn't have hospitalists, we didn't have doctors who didn't know us, who came in. You had to tell your story all over again. Something always gets lost in the translation. You never get to see your primary care physician when you're in the hospital. They don't come anymore.
Right.
Is there a reason other than money for that?
Yeah, it's that actually from what we have found, there's two reasons. One is it does get very difficult for a primary care doctor to just for how they, you know, they have their, when they get busier and busier, it's harder to focus on their practice on the outpatient side and then have to run over and see. It works when you're small, the bigger you get, the tougher it is. But frankly, what the clinical reason for having hospitalists is, so the things like these complex medical records, how do you get labs, all of those things, if you do it all day, every day, you know how to use the electronic medical record. And if you're a community doctor and just come in one day, you got to get to know your office medical record and the hospital medical record, and it's just hard to go back and forth. So from a money perspective, it is better for the primary care for us. It's frankly more expensive to have a hospitalist program because we have to, you know, the hospital has to provide that service where it used to just be done by the community physician. So this is a map of, so you think about who's taking advantage, who are the folks in that with the Medicaid. This is we did the last chart on the Medicaid expansion program. This is the map of Michigan, and it's hard for you to see, but these are what percentage of the population are in some type of the program that was like that. And in the red areas, it's 11% or more of the population, and then the lighter it is, it goes down to less 1%. So sometimes people think that this Medicaid issue is really a big city issue. It's really a rural issue. And in the state, this is the parts of the communities that are on those programs. And of course, Flint, you can see there are downstate areas, but it really disproportionately is, and again, with especially the moms and babies in northern Michigan. So so that's who pays the bills for hospitals. This is ours again. So where does the money go? About 52% salary and wages. We're very labor intensive business. 23% supplies, 7% interest, employed positions. And at the end of the day, it's on $1, we save about 4 cents or 4.5 cents. That's our margin after the end of the day. And so what happens with that 4.5 cents in the dollar? So as a nonprofit, so it all gets reinvested back in the hospital. It's not paid out to shareholders. So some of it goes into savings for things like building projects. I mean, that's basically what it goes for reinvestment through capital. And so I'll get to a little bit about how do we spend this money. But on the end, it's about 4 cents left in the dollar, and that's what we save. That's what goes into our savings account. Questions on that?
How much can you, as more of a nonprofit?
Save?
Yeah. What is there?
There isn't any regulation that says
No more than.
no more than. I think the high, certainly there would be a lot more public scrutiny at some point. If it got to be 25% or something, but
You
that's
wish.
I wish. I'll deal with that problem. Yes, sir.
Well, how much of the interest, insurance, and depreciation is depreciation? Because that's money you can reinvest too.
Yeah, I bet you it's a pretty good chunk of that 7%. Yeah, I mean,
So you've got roughly 8% or so available for investment.
because you're not cash, yeah.
Yeah.
That's fair.
How often does the government pay you? Like, do you get a lump, or how do the payments pay out?
Depends.
And you cash the check.
Yeah, so whatever you submit a bill, and it's pretty timely. Medicaid is worse than Medicare on billing turnaround, but they don't hold it. We send in a bill today within 30 days. That's what our goal is, within 30 days to get payment.
Okay, I don't know why, but I thought they'd hold them for months. I don't know why.
Sometimes that happens, if there's troubles with it depends on the system, the VA system we've been talking about. It's 6, 9, 10 months. I mean,
That's an awful long time.
but that isn't as a percentage of our payments, not that big. I would say the average payment's probably 30 to 40 days
Oh, okay.
for governmental payers. Yes, sir.
Many times I get a bill, it shows me a fee, what's being paid by the provider, and then there's a loss that somebody else is picking up. Major loss, difference in the fee charged compared to the fee paid by the
Yep.
provider.
Yep.
What happens to that loss?
Get written off.
You have to write all that off.
So hospital bills, I mean, it's really a screwy system. I mean, you would never, but the charges are, it's kind of like a rack rate on a hotel room. I mean, it's very, it's really done more for fee screens than it is for what you're actually going to collect. So our average payment as percentage charges is about 50%. So if a charge is 1,000, our average payment is about 500. That's, a big generalization. The rest of it we write off to what's called contractual allowances.
There's a lot of that what's driving down because that's a guaranteed rate that the provider's going to pay. Causes you not to have as much for reinvestment, other activities.
Well, the challenge purely from a business side is take the Medicare and Medicaid rates. We have there's no I mean, the government just says, here's what we're going to pay you, good or bad. Here's what it is, and that tends, and so that tends to be pretty flat given budget discussions at the state level. So the only way we have from a business to make it up is on the commercial side.
Okay.
That's the only place you have to do any negotiations.
So on the average of billing is most all your billing somewhat discounted by X percent?
Oh, 98% of it.
Is it?
Yeah.
It's just hard to run a business when you don't know where your income's coming from like that, and that's.
Yeah, the hard about business, again, 65% of your payments from something you have no control over.
Right. Thank you.
So one of the things I think, and this is on the federal side, we try to talk to our legislators on both sides of the aisle, is, so when you hear about cutting the budget in healthcare, there's a lot, like sequestration was a flat 2% or so, we think the focus needs to be on looking at where in the country we're spending the money on Medicare. So this is something done by Dartmouth University. It's called the Dartmouth Atlas, and by county, you can see how much the government spends on a Medicare enrollee. So this is adjusted for payer mix. So this is just Medicare. And what this says is that here in northern Michigan, we do a pretty good job. I think ours is $6,700, something like that, per Medicare enrollee. The government spends $6,700 per Medicare enrollee. You go down to Florida, it's almost $14,000. Same Medicare patient. And so part of what, our argument is Northern Michigan health system is, rather than cutting everybody across the board, why don't you look at the practices that are done in the upper Midwest and some of these areas where our cost for Medicare beneficiary is much lower than in Massachusetts, Florida, or Texas. And again, this isn't a Munson issue. This is true with Northern Michigan Hospital. Part of it is there's a lot of reasons for it. Part of it is the malpractice environment is better here. Part of it is cultural. Part of it is, we don't have as the hospital-physician relationship is different. But there's a huge variation in this country in what you spend on Medicare depending on where you live in the country. Yes?
Does immigration affect that?
I don't know. It'd be interesting to know, does demographic...
It looks like it's climbing from the south.
I don't have data. It's an interesting question to say, what does the demographic make up of that? I don't know.
Would the age of the people affect how much money they spend?
Well, this is adjusted, so these are Medicare enrollees, so these are all people over 62, and it's per enrollee. So it's not raw, like, clearly in Florida, there's more retirees, but you have more numbers. There's a bigger pot divided by more numbers.
Maybe they're older in Florida than...
We're pretty old up here. They say they adjust for that. It's always like anything like this, whether it's a perfect adjustment or not. But I think you could make that argument there, but you certainly can't make it in Massachusetts. I mean, it's just healthcare is delivered differently in different parts of the country. So, for the money we save, then what do we invest it in? This is last year, I think. So we invest about $64 million back into the community. From those, about $28 million are different types of facilities. This is for the system, for the region. About $10 million last year just on IT, and then $25 million in medical technology. That'd be things like labs and radiology and stuff like that. So this is the kind of stuff that hospitals, and this is pretty typical. But these you think about this for a small hospital, it's not part of the system. You just can't do it. So when it's nice to have the numbers, but here's the type of things. This is the Cowell Cancer Center, which has been open a couple of years now. Really a nice addition to the community. And then what you might hear about next, this is small, but this is the master facility plan for Traverse City. So anybody of you driven by, this was the parking lot, now it's being into a parking ramp. I hate spending money on parking ramps. It's just, but we kind of have to do it. And the reason why is this is the cancer center, and the only place left we have to build in our campus is the cross 6th Street in this parking lot between the cancer center and the main entrance. So the way this will work in the future when you come in, how you come in the main lobby now and you kind of walk up through the plants and everything, this will be at the same level, and so all of this you'll come right into that main lobby. And then you'll either go to the cross 6th Street, which is going to be Women's and Children's Services and a new neonatal unit, or you'll go to the other part of the hospital. That's our next big project is in Women's and Children's. We are now the only neonatal unit in Northside US 10. So neonatal unit is for really sick small babies. And the challenge is financially it's not really the perfect service, but you think about our families in northern Michigan having to drive Grand Rapids or down to Ann Arbor with a month at a time for these small babies. It's something we need to offer up here, and the way you deliver that care is completely different than it was 20 years ago. It used to be you were in a big room like this with bassinets all the way around, and now they're almost mini ICUs for these small babies. And then the other piece will be Women's and Children's. We have overflow. We have moms that have to be transferred off the unit. That isn't a great patient satisfaction, thinking of your scores if you're a new mom and get moved to a med surg floor. So that's our next big look. Yes?
Your children's center, is that going to bring more endocrinologists up here for you?
I hope.
Because that's a big problem.
It's one of the toughest recruits we have up here. Physician recruitment's a challenge for a lot of different reasons. So we certainly hope so.
Well, because I know with the endocrinologist, it's hard to get treatment up here.
It is.
For a young person. And if that young person goes in the hospital, it can take 3, 4, 5 hours to hear back from a doctor down at DeVos.
Yeah, We have several physician specialties. I wish we could recruit more. It's just, it's, to get them to come to Northern Michigan, there has to be some family. It's just, sometimes it's tough to recruit.
Is that the same for pediatric cardiology and neurology, which,
Well-
right now, when your kid is sick, they give you the choice of Grand Rapids or Ann Arbor, but most of us have kids at home too.
Yeah.
And you have to drive back and forth.
So our goal, besides the new building, is to have, what we're trying to do is to get them a lot more in these specialists, is to work with DeVos and U of M to have the specialists come up. We're going to be looking at setting up a new pediatric clinic at MCHC with DeVos. And so it'll kind of be like a building on Monday, it's a pediatric cardiologist. On Tuesday, maybe it's a pediatric endocrinologist. So it's in their best interest to have somebody come up, and it's our family's best interest. So I'm not sure we'll have enough volume to recruit our own of all those specialists, but it's to have the specialists come up rather than have people drive down to Spectrum or Ann Arbor. So what's going to be our focus? It's again, hospitals are shifting from just treating sick people to trying to keep them well, managing the health of our population. We really start to have to act like a system, so when you come into one of our hospitals, you can go back and forth and it's seamless. That says date, better use of date, it's actually data. How do we have all this information, how do we better use it to manage our population? And then we're going to have to continue to reduce cost. Healthcare is just too expensive in this country. There's a lot of different reasons for that, but we're going to have to do our part to reduce costs as well. So I know you had questions as you went around, but what other things didn't I cover, or would you like to question, challenge? Yes?
I have a question. Right before I was getting ready to look at Lansing, there's a lot going on up here about the nurses unionizing. What's been the fallout of that?
So we haven't even, so there is, M&A is representing the nurses in Traverse City. They had represented some of the other hospitals in the system. Short answer is nothing's happened. We have not started negotiation yet. So I can't tell you the impact until I see how where we go with that. So not much has happened. So, but I think it's just in that period. So we'll see. Questions? Other things? Yes, sir.
At the beginning, you were mentioning how you were trying to kind of get all the hospitals kind of in sync so you can go from where, and you said you're not quite there yet. What are kind of the things that are holding you back from getting
Information
there?
systems.
Information systems.
To have, right now, if you look at, our map,
Sure.
go back, we have about 20 different computer systems between the doctors and the hospitals. Our goal now is to have them all in one.
Okay.
So it's called a Cerner system. And
Sure.
it's, whether you're in Grayling or in Traverse City, to have your on one computer system, so the doctor can go in, and it doesn't matter whether you're in Traverse City or Charlottesville, your electronic medical records. And if they don't have that data, that's why they're re-asking, computers don't talk to each other. So it's,
Right.
I would say IT is the biggest challenge.
IT. Okay.
Down south, the shape, you want to go to a doctor, you call up, make an appointment, and you go. Up here, almost everything is by referral. Is that because of the limited number of doctors, or what? I mean, I wanted to see an allergist. No, you gotta call, you gotta have your doctor refer you to an allergist. And I had not ever run into that before.
Yeah, I don't know, it's interesting.
I said, well, nobody, and they said, well, have your doctor refer us, and
I certainly would agree it's common practice to not see a specialist until you see a primary care. That tends to be driven more by insurance than by geography. I mean, so each insurance is different in what they require, for referrals. So I'm not aware, I don't think our region's any differently. It may be a different mix of insurance. That almost always is a local insurance requirement. Do they let you do what you want, or do you have to go through some process? Other stuff?
Have you, now that you're, well, I'm going to just say it, now that you're kind of a quasi-government agency, 67% of your income comes from taxpayers, has that shifted how you interact with the politicians, with the elected officials? Do you spend more time now? I don't want to say lobbying, but discussing your issues with them?
Not even, it's probably been one of the bigger changes in my job. I mean, some of it's if I've had different jobs, but if you think about it, when, in my role, if or any of your businesses, if you had 70% of your payment coming from something, it is worthwhile spending time educating them, you know, having those discussions, because that has a huge impact on our patients and our business. Yeah, whether that's good or bad, you know, it's kind of it is part of the job.
Any other questions? Thank you, Ed Ness.
And thanks for having me.
Thank you, everybody, for coming tonight. If you want to mingle around and talk, we got plenty of time. Stay here, talk to everybody, or have a good night.